Welcome to today's American Community Media Weekly National Briefing. I'm Sunita Sarabji, Health Editor at ACOM, and your moderator for today's discussion. 20 million Americans enrolled in Affordable Care Act plans have been facing sticker shock as monthly premiums have doubled for many. Consumers face difficult choices as open enrollment ended yesterday in most states. Buying a low tier plan with higher deductibles and copays, or dropping off of healthcare insurance entirely. In an article yesterday, the New York Times noted that 1.4 million people have already dropped their ACA coverage, and analysts predict that more than 4 million people would drop out entirely as we see the numbers in March. Small businesses are scrambling to keep their employees covered, even as their premiums sharply rise. Congress has engaged in a fight to extend enhanced premium tax credits, and while the House did pass a measure earlier this year, the Senate is unlikely to take it up. In the US, healthcare spending has surpassed housing and food as a larger share of the economy and personal budgets, becoming Americans' top financial concerns. One out of every $5 spent in the US is spent on healthcare costs. Speakers this week will discuss the factors behind the high cost of coverage and care, including pharmaceuticals, and offer options for addressing the widening gap in healthcare access. Reporters, we will take questions immediately after each speaker presents and return to a final round of questions in our last 10 minutes. So please welcome our speakers. Meredith Basie, Executive Director of Patients for Affordable Drugs. Dr. Neil Mahoney, Professor of Economics at Stanford University and the George P. Schultz Inaugural Fellow at Stanford Institute for Economic Policy Research, and Anthony Wright, Executive Director of Families USA. So we begin with Anthony, who will brief us on the fight at the federal level to extend enhanced premium tax credits. Anthony will also address the large number of people who have dropped out of healthcare or switched to lower tier plans and what that might mean for the healthcare ecosystem at large. Welcome, Anthony.
Thank you, Sunita, and thank you everybody who has joined us. Really appreciate the opportunity to talk with you today about these premium tax credits, these premium spikes, and healthcare costs overall. My name is Anthony Wright. I am the Executive Director of Families USA, the national nonprofit healthcare consumer advocacy organization. We and we have been working along with many other groups to try to make sure that people did not face what they faced this month, a massive premium spike that on average will be over $1,000. But for the 20 million folks who are in the marketplaces, but in many cases, it's not just hundreds, it's thousands of dollars of costs. On average, it is over a doubling of their premiums, and in many cases, it's a tripling or a quadrupling. For a lot of low income people who maybe were getting coverage for at $0, $5, $10 a month. They're now paying literally hundreds of dollars. In some cases, people who are at maybe a little bit higher income or who are older are maybe getting a little smaller percentage increase, but getting actually a much bigger dollar increase. Literally, for folks in their 50s and 60s, we've seen um, couples in their 50s and 60s have to pay now more than $10,000, $15,000 for their coverage this year. That is a huge amount. And again, the existing policy that expired at the year was to basically put a cap on how much people had to pay as a percentage of their income, 8% for everybody, and then for certain incomes lower on a sliding scale. That guarantee goes up, and went away on January, and as a result, we have seen in the very initial statistics, 1.4 million people fall off of coverage. or just have lower levels of coverage as a result. But that we think is just the beginning and the tip of the iceberg of the impacts, because there's a lot of people who were basically automatically renewed into coverage um, in January, and we will. I expect that we will see them many more folks fall off of coverage as um, they are not able to pay that higher premium in January, in February, in March, especially after certain grace periods and other things come into effect. So I think we've seen an initial drop of coverage, but I think we're going to see a lot more of it. And you know, with open enrollment ending just yesterday, millions are now stuck with a massive health insurance premium spike and an awful choice caused by the deliberate decisions of the president and congressional leaders. So some may have felt the sticker shock and have already dropped coverage, while others dropped down to lower tiered coverage with sky-high deductibles, paying more and getting less. We expect many will try to pay their premiums of hundreds or thousands of dollars more in the next few months, but and forego other necessities, but some may end up uninsured over the next several months. So just a lot more people who are as a result of these deliberate decisions by congressional leadership, by the president, we are now going to be facing millions more Americans who are uninsured and underinsured. And what's troubling about this is that families across the country desperately needed these congressional leaders to address this issue of healthcare affordability. After a presidential election focused on affordability, extending healthcare tax credits for working families should have been a no-brainer for every member of Congress. But rather than representing their constituents, including in their own states that are disproportionately impacted, Republican congressional leaders ignored them and ignored the constant barrage of calls for solutions for greater affordability. These major premium increases were entirely preventable. A majority of both the House and the Senate have now voted to extend premium tax credits for 3 years. Despite we just again, just a week or two ago, 17 Republican members in the House voted for these ACA marketplace of tax credits. That is a historic amount of bipartisan support in the Congress. There is broad support. There is broad public support for this affordability assistance in the public by every poll that we have sown. And unfortunately, we have congressional leadership continuing to use procedures and poison pills to block the passage of any effort to stop this spike in health premiums. For the past year, they've repeatedly rejected extending these tax credits, even as they approved other extensions for cuts to the wealthy and corporations. And so much of the damage has already been done, but we will continue our efforts to extend these tax credits to find a way to get the Senate to pass a clean extension, just like the House did, since Americans are trying to afford health coverage. We'll always still need the help, even if it's done retroactively. So the fight is not over. Open enrollment may have ended, but the fight for affordability has not. Um, and I know that my colleagues later on will talk about some efforts to directly address why healthcare premiums are so high to begin with. But people also need this guarantee that they don't have to pay more than a percentage of their income on coverage, whether it's 10, 15, 20, 25%, that there should be some limit on how much they are paying out of their family finances. And then we also have to do what my colleagues will talk about why healthcare is so damn high to begin with. So with that, let me stop and really want to get to your questions.
Thank you, Anthony. First question from me. If the Senate were to take action now, what would that mean for the millions of people who have already enrolled or dropped out? Will we have to wait until next November for open enrollment?
So I think if they were to pass something, it likely would be a compromise. And in that compromise, one of the things that we would expect and we would advocate for is that there would be a new open enrollment period, so people can make adjustments, whether it's people coming in to get coverage because they were scared away by the sticker shock of the new higher premiums, or for people to say, hey, if we get that additional assistance, I can again buy up to from a bronze to a silver plan, for a silver to a gold plan. Because again, for those people who maybe were on a silver plan, if uh, and they found that they could no longer afford the silver plan with the higher premiums, they could drop down to a bronze plan, but that means a plan with a $7,000, $10,000 deductible, which and that may provide very little help, especially for folks who are already in the lower incomes anyway. So I think that that would likely come with an open enrollment period, and if nothing else, for the people who are still covered, this is a tax credit, so it all gets reconciled in your taxes everywhere anyway, and so this could then provide some fiscal relief both partway through the year and at the end of year, um, with a tax refund or something.
There are several questions for you in the chat. Let's get to those. Anjana Nagarajan Bhutani from India Currents, please ask your question.
Hi, so I was just curious if you have data by state on the number of folks affected, and I'm, of course, interested in California data.
Yeah, so a part of the good news is that California is one of I mentioned that open enrollment ended at the in 43 states, so in most of the nation, but there's a handful of states with their own state-directed marketplaces, like California, that could go to the end of the year. So that data is not yet available because the story has not yet been fully written, and likely Cover California will put out its own data when it can be vetted. I think it's also really important to recognize that even the national data is very preliminary because A, we literally just hit the open enrollment just yesterday, and B, again, a lot of the people who may fall off of coverage uh, may not do so for another month or two as you know, as they find out that they really can't pay that premium. Then it'll take a month or two for them to have fallen off of the coverage and for their coverage to be disenrolled.
Thank you. There's a question from Araceli Martinez of La Opinion. Araceli.
Hello, Sunita. Hello, Happy New Year. Um, I was wondering if, in practical terms, if there is anything that can be done to lessen the impact, and I wonder if this is going to be felt equally in all states, and finally, if California is doing anything to lessen this blow. Thank you.
Yes, so a couple of things. One is in terms of what people can do in terms of their options, including those people who are still in an open enrollment period, like in California. I mean, I think number one is to first of all, use the official websites, healthcare.gov, Cover California, others. You don't want to be caught in one of these scam websites that may refer you to coverage that does not have comprehensive benefits that might be junk insurance. Number two is to shop and compare. The best deal last year was not necessarily the best deal this year, especially with this dramatic change in the expiration of some of the subsidies that are available. Recognize that the baseline Affordable Care Act subsidies are still available. So the enhanced tax credits expired, but the tax credits in the original Affordable Care Act are still there, which do provide some protection, especially for those folks under 400% of the poverty level. Although the enhanced tax credits did more for those under 400% and something for those of over 400. There is still help for those under 400% of the poverty level, which is 60,000 for an individual, 125,000 for a family of four. And then third is that there is this option. It's not a great option, but it is the option of, for some cases, it is to buy down coverage that maybe that premium at the gold and silver level is just too expensive, but maybe at least you can get a lower premium if you do a bronze plan, it does mean that you are paying more and getting less in terms of a high deductible, but you still have the coverage of that if you have something catastrophic happen to you, that will be covered and you won't, go into full on bankruptcy. That you still in a place like California, even the bronze plan gives you 3 doctor's visits to be able to get to see uh, to get primary preventive care, preventative services, some initial doctor visits, etc. So those are important things, important potential options. It's not great that one of the options is to go uninsured or underinsured, but that may be the reality for some folks. And then finally, you mentioned there are some states that are taking proactive actions to try to help people. New Mexico, for example, passed some additional subsidies to help people um, to help lessen the burden of these additional spikes in premiums. I know California is had a pot of dollars that was going to help buy down people's deductibles and cost sharing, and that could go to help ameliorate some of the premium increases. But what the states can do is a fraction of what was in the federal deal. So we need federal action. The real solution is in the Senate, but states can do some work, and we're advocating for that.
Thank you. Rebecca Bartis has the next question. Rebecca, welcome.
Hi, yes, thank you. I'm wondering if there are any statistics available for how many immigrants specifically are expected to lose access to health care.
So there's actually several 100,000. As a result of both administrative and legislative efforts federally, um, again, in these federal actions, the federal and then there's I think additional impacts at the state level, especially in states like California, Illinois, and Minnesota that had rolled back what they were doing at the state level. So I can uh, I can follow up with you afterwards with specific data that and refer you to groups like Protecting Immigrant Families, the National Immigration Law Center, and others on specific data. But in the big budget bill, HR1, there's no undocumented immigrant that gets coverage through federal health care federally. But what that bill did was actually rip away coverage from a number of categories of legal immigrants, people with documentation, including um, domestic abuse survivors, trafficking victims, others. There was administrative actions to undo the administrative coverage that allowed folks that had DACA status to get coverage on the exchanges. So that was a loss. So I think that the calculations are in the hundreds of thousands of folks uh, who are legal immigrants who have lost coverage as a result of HR1 and then through other administrative means. And then because of both the political and fiscal environment, some states that had done some specific programs or coverage efforts for immigrants in their states, like California, Illinois, and Minnesota, have done some like freezing or rolling back of those expansions, and that's a further detailing if you're looking for a one big number.
Thank you. Our final question for you comes from Henrietta Burrows. Henrietta, welcome.
Thanks so much, Sunita. Anthony, what's the option for those losing their coverage? Is it going to emergency rooms? And will that eventually increase the health costs for all of us?
So yes, that's I think when people fall off, the big impact for many people of these tax credits expiring is that they will be paying more and getting less, and it's just a huge hit to their family finances. Some will fall to be more underinsured, some will be fall uninsured, and I think that you're absolutely right that then does have a cascading effect to the healthcare system that we all rely on. If community clinics, if hospitals, if other providers have more uninsured and fewer paying patients, that has an impact on on their financial stability, on their ability to keep their doors open, or if they need to that ends up being an encouragement for them to scale back services as a result. Um, as they have, again, if they have fewer paying patients, if they have more uncompensated care, that puts a financial stress on the healthcare system as a whole. So that's a big and important thing to consider, and also that has an impact by having fewer for people who are, especially in the individual insurance market. If people fall off coverage, that means that the insurers are covering a smaller and sicker pool because the people who fall off will tend to be healthier. And so that means premiums will rise as a result as well. So this has a cascading impact on increased costs and on decreased services for everybody, not just those who are directly impacted.
Anthony, thank you so much. Please stick around for a final round of
Please.
questions. We move next to Stanford economist Dr. Neil Mahoney, who will offer perspective on healthcare as the lion's share of a household budget and also some of the drivers behind the high costs of care. Dr. Mahoney will also discuss the impact of costs to employers, particularly small businesses who are scrambling to insure their employees, and a plan to extend Medicare coverage to non-elderly people. Welcome, Dr. Mahoney.
Thank you, Sunita, and it's great to see all of you. I have a lot of ground to cover. I've been thinking about healthcare markets and teaching health economics to students for nearly 2 decades now. And so I will try and lift up and talk about the problems of cost and access in the United States, how it impacts our economy, small businesses, and families, and talk a little bit about solutions, and then very much looking forward to your questions. And forgive me, I'm an economist, so I'm going to give you some numbers, but not too many. Over the last 2 generations, healthcare expenditure in the United States has grown from about 8% of our gross domestic uh, product, the sum total of everything we produce in the United States, to about 18%. So it is more than doubled. And that puts the United States now spending a larger share of our resources on healthcare than any other country in the world. In fact, compared to our peer countries, on average, we spend twice as much as a share of GDP. Uh, why do we spend so much? Well, Americans have a different mix of health conditions, a different disease mix, and we do consume different healthcare services. But the most important driver, and health economists will quibble whether this is 70% or 80% or 90% of what's going on, is the prices are too high. For everything from drugs to hospital care, we pay higher prices than almost everybody else in the world. And you can see this if you've looked at a hospital bill, or if you've been to CVS to pick up a prescription, that the prices just don't really make sense. So those high prices, those high costs, have big impacts. The federal government, I think, rightfully covers close to 50% of our healthcare costs because it's unaffordable for millions of families. But that does mean that it crowds out other forms of federal expenditure. 1/3 of our federal budget is healthcare expenditure. And that means we have less resources for other worthy endeavors. That's fact one. Fact two is the average cost of health insurance for a family this year, which is, for many of us, our employers contribute to significantly, is $27,000. Right? That's for $27,000, you can get a decent car. That's how much we are paying for family coverage every year on average. And so that is a huge amount of money. And if you are a small business owner or you are a firm trying to make it in a difficult environment, uh, providing that health insurance, even if you think that's hugely important to your employees, is a huge weight on your bottom line as a business. So $27,000. Those are the most recent numbers coming out of the Kaiser Family Foundation, KFF. Uh, and the third point is, of course, the government and employers are not picking up all of the cost. And so we've seen if you get 160 million Americans get health insurance through an employer, the premiums that we pay out of pocket have increased faster, much faster than our wages for that employer-sponsored insurance. The deductibles we face, so the amount of money you have to pay until your health insurance chips in, those amounts have risen dramatically. Um, and we see a similar story elsewhere, as the first speaker talked about. For those of us who get coverage on the exchanges, those premiums are skyrocketing this year. Many people will be forced to have less generous plans, which will mean higher deductibles. And you see similar stories for people who get healthcare elsewhere. So high healthcare costs driven by high prices are impacting the federal budget, are impacting our businesses, particularly small businesses, and are impacting families. So that's point one. Point two, what can we do about it? And, like many complicated problems, there isn't, one quick fix to reform our healthcare system. And to make meaningful progress, we actually have to push on all of the available levers. So what are those policy solutions? Um, One, it's making sure that there are enough healthcare workers, in particular in rural communities, in other underserved communities. Right now, there are caps on the number of doctors who can train, on doctors who can move from abroad to the United States and work in underserved areas. There are restrictions on what nurses and advanced practice professionals, on the care they can provide. And they're hugely important, especially in rural areas. So I think there's work to be done in terms of lifting those caps so that we have more supply of healthcare workers. I know for me, and I think this experience is broadly shared, that there are too long wait times to get a primary care appointment, to get a specialist appointment, to get your kids in for routine checkups. And one of the constraints there is the supply of healthcare workers. That's bucket one. Um, the second bucket is to control costs faced by families. And part of that is reversing some of the harm that's been done, especially this summer with the big budget bill. And so, as Anthony spoke about, we had the failure to extend the enhanced premium tax credits at the same time that Congress was passing large tax cuts for people who don't need it. And so, I know there's a fight underway to reverse that. Uh, Also, for people who rely on Medicaid, we are throwing sand in the gears of the processes that people use to apply for and continue Medicaid, and that is just complete junk. Right? That is going to push people who uh, need Medicaid and are and qualify for Medicaid off the plan in ways that will be harmful for their health and cause higher costs for our system. So it's important to reverse those so-called work requirements, which are really just administrative burdens. Uh, So that's one bucket of activity, which is reversing the harm. But we also need to be proactive and do things to expand coverage. So what are the policy options there? Uh, so, one is the Medicare program. I think both health economists like myself and regular people know that this is an incredibly strong program. It's also efficient. It has lower costs in part because the government has negotiating power and increasing access to Medicare, for example, by allowing uh, sort of near elderly, let's say people over 50 years old, to buy into Medicare, breathing more competition into the health insurance exchanges, the ACA exchanges, by revisiting the idea of a public option. I think those are important steps which are good for families, and they're also good for our markets because we are allowing a highly efficient Medicare system to discipline the market to compete with private providers. That's one area. For many families on Medicare, so elderly Americans, that coverage is great, but they may not have access to dental, hearing, and vision services. And so, in terms of caring for elderly Americans, I think there's an important discussion around expanding Medicare and expanding Medicaid as well, which is the program for the poor, to cover those additional surveys. If any of you have had tooth pain, it can be debilitating. And for people on a fixed income or living paycheck to paycheck, not being able to get the care they need to address that tooth pain or vision issues is debilitating. And so addressing that as well, I think, is an important policy discussion. The the third thing I'll bring up is drug costs. And so, I've crunched the numbers. Many other people have come to similar conclusions. Drug costs are not a huge fraction of our health care expenditure as a government, but they are a huge pain point for everyday Americans, right? They're a cost that we face every week when we go to CVS and Walgreens. They are costs where we face a higher fraction out of pocket. And many of us have to make very difficult decisions around whether to take drugs we're prescribed or to save our fixed incomes for groceries and other skyrocketing bills. And so, we saw some steps forward on drug costs with the federal government negotiating down the prices of drugs for Medicare. But I think we fell short of what is needed in terms of expanding those negotiated prices to everybody with healthcare, to increasing the set of drugs we negotiate, so that there are really exciting developments in um, in healthcare technology and in drugs. Those may be turbocharged by AI, by CRISPR, by other innovations, but uh, it's not good enough just to have innovations that are available to the few, that we need to tackle drug costs so that those innovations are available to everybody. Oh, take a quick look at my note. I guess I'll mention one more thing and then open it up to questions. Um, Another way to address the problem of high prices in our healthcare system is to make markets more competitive. And so, we've seen, I think, particularly appalling practices, private equity firms buying up small physician practices in what are known as roll-ups, and then using their monopoly power to extract higher payments. Uh, we should be supporting the antitrust agencies to block and root out that behavior. Uh, but stronger action may be required. And so the idea of expanding Medicare and expanding drug negotiation, I think even economists who tend to be skeptical about price controls and about the public sector realize that more forceful medicine is needed in the healthcare sector to address the problem of high prices and are supporting more aggressive policy.
Dr. Mahoney, there are a number of questions for you, but I'm going to start out with one. A lot of our conversation thus far has focused on premiums. I'm concerned about copays, which has not been focused on at all yet. The high cost of copays, just to see your doctor at this point, cost you somewhere between $80 and $100, even if you've got great coverage. Are copays keeping people out of the healthcare that they need? Or are people foregoing other things they may need in order to be able to pay that copay and see their doctor?
It's a great question. And I think it's an area where economists were originally wrong, but where the evidence has shown them the impact of copays. So if you go back 50 years, there was an idea that if you give consumers skin in the game, right, have them pay for some of their health care, they would cut back on unnecessary expenditure, superfluous, wasteful expenditure, but they would continue to consume the care they need to manage chronic conditions, to catch things early. But what we've seen from a generation of evidence is that when you expose people to costs, they cut back not only on care which may be of questionable merit, but on things they need. Taking drugs to manage diabetes or high cholesterol or blood pressure, not getting routine checkups and screening. And so I think the consensus has thankfully shifted. And I think probably people who are smarter than economists knew this all along. But my tribe has now realized that this cost sharing creates much more harm than benefit. And I think there should be an important policy um, agenda to removing cost sharing from really any of the necessary medical care that people need. We've done that for preventative and well child visits as part of the Affordable Care Act, but there's much more work to do.
Thank you. Fatma Bucket has a question that I have. Fatma, please ask your question.
Hello, how are you?
Good, thank you. How are you?
I'm doing fine, thank you. I have two questions. How do the raising insurance cost affect small business ability to hire, raise wage, or stay competitive? And the second question which is, why are the same prescription drugs almost 60% or, or more expensive in the US than any other country?
Fatma, Merit can answer your second question, but let's have Dr. Mahoney answer your first.
Okay, no problem. Thank you.
Thank you.
Great. So there is a body of evidence that shows that when healthcare costs rise for businesses, they do one of two things. One is they lower the wages they provide to workers, because if anybody here who's run a business knows, you don't think about wages, you think about total compensation. And so if healthcare costs go up, you give people a smaller raise, or when you're hiring someone new, you reduce the wage offering. The other thing they do is lay off workers or not hire. And right now we have a completely frozen labor market where if you're looking for a job, you're going to have a really tough time. And so I don't think we've connected the dots yet from rising healthcare costs to a frozen labor market, but certainly the body of evidence we have suggests that higher healthcare costs mean lower wages and less jobs.
Thank you. Jennifer Liu has the next question. Jennifer? She may not be on. We'll go to Nafiso Ahmed. Nafiso's question is similar to Fatma's, but Nafiso, please do ask your question. I can ask it for him. Our rising premium is making it financially impossible for many small businesses to continue offering health insurance. And what does that mean for the future workforce?
Yep, and that's a great point that the third option for small businesses is to not provide health insurance to their workers.
Right.
Uh, and that's a very difficult decision for a business owner that cares about their employees, especially with spiking premiums on the exchanges. Because then those families may go without health insurance, which creates stress and has impacts on productivity and on the ability of people to show up and be focused at work.
Interesting. Itana Vargas asked if I could answer her question. Trump has just announced his great healthcare plan, although it's just a one-page document. Is there any hope that his plan could make the situation less daunting?
Look, I think I want to give the benefit of the doubt to anybody who wants to address the healthcare issues in this country. Um, you know, Trump has a track record of saying that he's going to solve healthcare next week, and he hasn't delivered for years. And so, the track record is not encouraging. I'll say one other thing, which is the go-to Republican solution to healthcare costs is to provide tax-preferred savings accounts. Uh, and that sounds great. But there's two things to keep in mind. One is $1,000 or $2,000 in a tax-preferred savings account uh, is not going to measure up to the problem if you actually get sick. If you think about the costs that people have to pay, around a hospitalization or other acute condition. Two, who benefits the most from tax preference savings? It's the people with high tax rates, which are the wealthiest people. And so I think it's important to be clear-eyed about what these policies are doing, which is they're not providing enough benefits when we need it, and they're targeted to the wealthiest among us.
Interesting. Before I let you go, I have one final question for you myself, which is the latest jobs report, which, as you mentioned, we have a frozen labor market, but there were a number of new jobs in healthcare. So what are employers thinking? Are they going to be addressing a greater number of people, even amid people dropping out?
It's a great question. So you're completely right that over the last year, uh, healthcare job growth has been driving the economy, the jobs market. Uh, Part of that is catch up from the pandemic. That over the pandemic, healthcare workers left their jobs and there was a huge slowdown in hiring. And so, we're just catching up. Um, but part of it is, I think, unexplained. Actually, part of it is an increase in home health and other care. People, are rightly worried about going to nursing homes given everything we saw in the pandemic. So there's been scaling up of home health aides. It's a dynamic environment.
Thank you. Dr. Mahoney, thank you so much. There are many questions for you in the chat. If you could answer them there, that would be terrific. We move on to Meredith Basie of Patients for Affordable Drugs. Meredith will discuss why pharmaceutical costs are so high and measures to bring down the high cost of drugs. Welcome, Meredith.
Thank you for having me today. Let me start by just introducing Patients for Affordable Drugs. We are the only national patient advocacy organization that focuses exclusively on policies that lower drug prices. And really important, I think, for this conversation is that we don't take any money from the pharmaceutical industry or from anyone who profits from the development or distribution of prescription drugs. So today, we've heard some sobering data from my colleagues, but the reality is that 1 in 3 Americans and people in this country cannot afford to pay for their prescription drugs. And Americans are paying between 4 and 8 times, at least on average, what patients in other high-income countries are paying for the very same brand name drugs. And the reality is it doesn't have to be this way. The reason it is, I will talk about, and some of the solutions. But the key point here to understand is that it's pharmaceutical corporations who are setting those launch prices, and they are controlling the market through their monopolies. And Congress, until recently, has allowed for these practices to continue. So those are sort of the top points. But why Americans are paying more? The primary reason, or one of the primary reasons, is that other countries negotiate drug prices. And Neil mentioned Medicare negotiation. And just a couple of weeks ago, on January 1, that changed. And I'll explain that now. But I think that key piece is what has prevented the US from being able to maintain prices at a level that is more affordable for American patients. Also, second, the pharmaceutical industry is well known for abusing the patent system. They manipulate the system in a lot of different shady ways to ensure that they can maintain their monopolies for as long as possible and to prevent competition. So we know from research from the FDA and other places that when a generic medicine enters the market, you can reduce the price of a drug that's already on the market by, on average, a 39%, which is significant. If you have 5 or 6 competitors, you're going to see a reduction in those prices by about 95%. So a lot of the practices you see from the pharmaceutical industry is to prevent those generics, delay those generics from hitting the market because that competition in a free market would lower prices. So that is part of the reason, the prevention of competition. The pharmaceutical industry also sets prices. So when a new drug enters the market, the launch price is not set by the government. It is set by the pharmaceutical industry, which again is quite different to a lot of other countries around the world that have a system that allows for a better return on public investment and other factors in terms of the value of the drug to patients. That doesn't exist in the current system that we have. There are other actors who look at that kind of data, like ISA, and look at the value of a drug. But that is not the way the system works at present. And then if you think of the entire system here in the United States, every step of the way, somebody is profiting, right? So whether it is the insurers, whether it's the hospitals, obviously from the beginning where the pharmaceutical corporation sets the price all the way through, you're going to see an increase as a result. And pharmacy benefit managers, you'll probably have seen are in the press a lot. And the pharmaceutical industry is also trying very hard to point the finger entirely at them. They do play an important role in keeping prices high, but they are not the only actor. So the pharmacy benefit manager reform is also something that should be on the agenda if we're looking to lower prices. But in terms of what all of this means for patients, we know that recent polling has shown that 47% of people in this country are concerned that they're not going to be able to pay for a healthcare cost in 2026. 47%, which is shocking. And for many of the reasons that have been described, but that also includes being able to pay for prescription drugs. So we have patients in every single state. You can see about 40,000 stories on our patient map on the website that share people's lived experience of what they're doing in order to be able to try to pay for their medications. That means that people, for example, some people who are on expensive cancer medicines have, until recently, been having to pay copays that are in the tens of thousands of dollars. The good news, or the one piece of good news that has been mentioned already, is that as a result of organizing from groups, including Anthony's group here on the Core Families USA, ours, Patients for Affordable Drugs, and many others, we have been pushing for the passage of these drug pricing reforms in the Inflation Reduction Act that went into effect in 2022. The most pivotal pieces for patients are two things: Medicare negotiation and some of these caps on the price of out-of-pocket costs that patients are going to have to pay. Which means that it really is helping patients be able to manage those costs. But still, at $2,000 a year for people on Medicare, that can still be a lot of money for a lot of people, especially uh, people who are lower income. I think with regard to Medicare negotiation, on January 1st this year, we saw for the very first time the first 10 drugs, the costliest and the most commonly used drugs. So that includes like diabetes medicines, insulins, cancer drugs, immunotherapy drugs, that the new prices went into effect, which were about 63% less expensive than they would have been previously. And that is because after 20 years of the pharmaceutical industry preventing Medicare from negotiating drug prices, even though Medicare was allowed to negotiate for every single other product it paid for. And there's a whole story about why that happened in the dead of night. It sounds like a Washington sort of TV show or something, but it really is what happened. And a clause stuck in the dead of night that has forced Americans who are on Medicare and the US government to pay the prices that they have had a chokehold on Americans for so long. So that is good news. And we will see more drugs in the coming years. This is the expectation, up to 60 of those high-priced drugs that will be, we hope, brought to market now at a lower price. I will say that there have been a lot of serious threats in terms of whether or not this program will be successfully implemented. But we learned in November that the Trump administration also announced similar price reductions at around 63%, which is encouraging, even though the industry filed at least 10 lawsuits to try to undermine this program. So that is top of mind. I'm just trying to keep an eye on time here because I realize I could probably talk all day on this. So I can, if you want, I can stop there, or just share a little bit more about Trump RX and some of the other threats. But Sunita, let me know. And I know we also were going to mention some things in Spanish, but you tell me.
No, let's go to questions because there are a number of questions for you. I will start out with my own question. Is it as simple as limiting patents to, say, 15 years and then going to generics after that?
So you could reduce the exclusivity period. That would certainly help. There are other tricks, though, that the industry has, whereas they patent, say it was insulin, for example, they're not just patenting the product, they're patenting the pen, they're patenting the needle, the delivery device, so that these thickets make it really hard for a generic competitor to enter the market. And they also have other tactics where they actually pay off generics. Pay for delay is what it's known as. So they pay them off so that they delay entry of their product into the market. And there are actually bills in Congress which are bipartisan that we and Families USA are supporting that have left committee that could help tackle some of these root causes to this problem.
Thank you. Our first question comes from Nafiso Ahmed. Nafiso, please ask your question.
Hello. My question was, how should Congress address monopoly pricing and patent extensions that keep drug prices high?
Great question. The important thing is there are a couple of bills in Congress right now. The one that is most exciting is the Ethic Act, which would address some of what I've been describing in terms of patent reform. There's also another bill which is similar but wouldn't go quite so far, that actually got a long way in the last Congress, and we're hoping we can get it across the finish line this year, that would also address some of the challenges with patent thickets and then product hopping. The other thing that we need to see is increased coordination as well between like the FDA, for example, and the USPTO, the Patent Office, and increased transparency. There are a lot of different ways that we could increase the competition to drive more generics and biosimilars to market. But that's what we see at the top of mind. But I will say the primary way that we do need to think about is launch prices, and taking away the massive amount of power that the industry has is setting those launch prices, which is why you're seeing seven figures attached to some of the new cell and gene therapies, especially for things like sickle cell, for example, that are coming to market. But there is plenty to be done. And the good news is that 80% of Americans support patent reform, and 9 out of 10 Americans want Congress to do more to lower drug prices. So it is politically a very good idea wherever you sit on the political spectrum.
Thank you. Reporters, I hope you'll stick on for an additional 5 minutes because we do have a few more questions and then final remarks. Merit, the next question comes from Henrietta Burrows. Henrietta, please ask your question.
Thanks so much, Sunita. Merit, you talked about the generic drugs, so I'm going to ask you, you also mentioned Trump, and he was negotiating supposedly to lower drug prices, and you mentioned the lawsuits. So I'm wondering, since he's been good at signing executive orders, do you think he could, that there might be the possibility of him signing an executive order to make that 63% reduction in drug prices that he's advocating?
So the good news is that the president inherited the Medicare negotiation program, and the prices that they announced in November were for the second round of drugs that are in that program, and they have negotiated a similar discount to the previous administration, around 63%. It's 15 drugs this time, so 5 more, but that was part of the mandate. So we were really pleased, and patients in our community were really pleased to see this program go forward under the current administration. Also, I should mention that the DOJ under the Trump administration has also defended the lawsuits against the pharmaceutical industry. And another piece of good news is that so far, 16 times with judges appointed under Bush, under Trump, under Biden, under Obama, have ruled in favor of patients. Now, the industry has a lot of money and expensive lawyers, and so they are now petitioning the Supreme Court, and we will find out in the coming days what might happen there. But we are involved in playing a role to support patients in this case.
Merit, there are a number of questions for you, but we've run out of time. Let's go to final remarks from each speaker. Merit, let's start with you.
Drugs don't work if people can't afford them. We know that the US is paying the highest prices in the world because pharmaceutical corporations are allowed to block competition and avoid negotiation, but we're finally changing that. But the industry is powerful, and they're attacking the reforms that we have made, so we need to keep advancing. Y la última cosa que quería decir que también estamos organizando en español, entonces para la gente que habla en español, tenemos materiales en español para todos y hasta la página web, etcétera, y pacientes con quien se pueda hablar. Okay.
Thank you. And we should note that Patients for Affordable Drugs Now has an archive of 40,000 patient stories, which would be hugely important to each of your reporting. Dr. Mahoney, your 30-second soundbite.
Healthcare in the United States is too expensive, squeezing family budgets, harming our small businesses and larger businesses, and putting real strain on our government's debt and deficit. The good news is that there are programs that work very well, from Medicare to drug price negotiation, and we can build off those successes to make healthcare more affordable and accessible. But it's not easy. What you and I might call waste is profits for one of the healthcare corporations, and so it takes sort of everybody rowing in unison to bring the fight to the people with their hands in the cookie jar.
Terrific. Anthony, last word.
Yes, I would just say we, people are screaming for relief. This is literally one of the top issues that people are struggling with right now. Affordability in general and healthcare affordability specifically. They've been complaining about the price of chicken or eggs for the last couple of years. They've been screaming about the cost of healthcare for decades. We need to a bold effort to address this, both on the front end and the back end. That means to give people a guarantee that they don't have to spend more than the percent of their income on coverage, like with the tax credits that just expired, but also to deal with these root causes of why healthcare costs are so damn expensive to begin with. And that means the broken incentives that and the market failures that Dr. Mahoney was talking about, or that Meredith was talking about with regard to prescription drugs, that are where the incentives are to get bigger, not to get better. There's so much to do in that regard, but we need to do both, and that's the work and the advocacy of the next couple of weeks in terms of seeing if there's still effort to get the Senate to pass the extension of the tax credits, but also the work of that should be the entry point. That should not be the end of the conversation. That should be the entry point to a broader discussion of dealing with affordability in healthcare. And we hope that you continue to cover this. Thank you.
Speakers, thank you so much. This was a terrific briefing. I think we all learned so much. And reporters, thank you for joining us today. We'll see you next Friday. Take care.